Greetings, everyone. Today's recorded presentation will focus on the intersections of the HIV, viral hepatitis, and substance use, and how data is being used to drive action. My name is Amber Coyne, and I am the End This Endemic Tennessee Coordinator for the state, and I am joined by my colleague, Lindsay Sizemore, the Director of the Viral Hepatitis Program at the Tennessee Department of Health. Lindsay?
Hi, everyone. So let's just jump right in. So let's start with some of the basics. HIV, or human immunodeficiency virus, is an infectious disease transmitted through certain body fluids, including blood, sexual fluids, and breast milk. HIV is not curable, but it is treatable. HIV is treated with antiretroviral therapy, also called ART. These medications reduce the amount of virus in the body, leading to better health outcomes for the person living with HIV. These medications also reduce the amount of virus in body fluids and reduces the chance of transmitting virus to others if taken as prescribed. This principle is sometimes called U equals U, or undetectable equals untransmittable, which means if the number of viral particles of HIV in someone's body is reduced to undetectable levels through the use of medication, then they cannot pass the virus to others through sexual activity. Hepatitis C virus, or HCV, is also an infectious disease and the most common bloodborne pathogen in the United States. It is transmitted in a variety of ways, but mainly from sharing drug equipment to inject or snort drugs, occupational needle stick injuries, being born to a person with untreated hepatitis C, and getting body piercings or tattoos in an unregulated setting. Despite hepatitis C being curable, it kills more people every year in the United States than HIV, tuberculosis, and 58 other reportable infectious diseases combined. Treatment of hepatitis C has come a long way. Current therapies cure over 90% of people living with hepatitis C, and treatment can be as simple as one pill a day for 12 weeks. There is notable overlap of HIV and hepatitis C due to these shared modes of transmission, including exposure to infected blood or through sexual contact, although this is less common in hepatitis C. Due to these shared modes of transmission, persons living with HIV are disproportionately impacted by hepatitis C. It is estimated that 1 in 4 people living with HIV are co-infected with hepatitis C, and that 80% of persons living with HIV who inject drugs are co-infected with hepatitis C. Compared to HIV, hepatitis C is 10 times more infectious and is able to live on surfaces outside of the body for up to 6 weeks. This contributes to the large number of newly reported cases of hepatitis C that Tennessee is observing each year. Speaking of, in 2018, nationally, Tennessee had the 16th highest rate of newly diagnosed HIV and the 6th highest rate for acute hepatitis C, as well as the 4th highest number of newly reported cases of confirmed, or by REMIC, chronic hepatitis C. As of December 31st, 2018, there were over 18,000 Tennesseans living with HIV and over 106,000 Tennesseans who have or have had hepatitis C. As a caveat, the Tennessee Department of Health did not begin to conduct chronic hepatitis C surveillance until mid-2015, so the true number is likely much higher.
The shared mode of transmission between HIV, other sexually transmitted infections, and viral hepatitis in the wake of the opioid epidemic has created what we call a syndemic. A syndemic is a set of overlapping epidemics that fuel each other, leading to worse health outcomes. We know that communities often face many health challenges at the same time. So how do we decide what health issues to include in a larger syndemic? The original theorist, Singer, outlined 3 criteria for determining what co-occurring epidemics are part of a larger syndemic. The first criteria is simple. The data must actually show separate epidemics are occurring at the same time in a given community. The data in Tennessee indicates we indeed have co-occurring epidemics for HIV, sexually transmitted infections, substance use disorder, and viral hepatitis. Secondly, the health conditions must somehow interact within the body through biological mechanisms or through some sort of shared behavior that worsens the health outcome. There are many examples that connect these four health conditions. One example is an individual with a syphilis infection is more vulnerable to acquiring HIV at the site of the syphilis infection, which makes it easier for the HIV virus to enter the body. In terms of behavioral connections between these conditions, we know that sharing syringes and other drug injection equipment can transmit HIV and viral hepatitis. Lastly, there must be common underlying systems level factors that contribute to and sustain the included epidemics. Some common system level factors we often hear about in the context of HIV, sexually transmitted infections, substance use disorder, and viral hepatitis are the housing crisis, poverty, lack of healthcare access, criminalization laws related to HIV and viral hepatitis, homophobia, and more. One prime example of how a syndemic can play out in real life is the story of Scott County, Indiana. Scott County is not so different from many communities in Tennessee. It is small town America with a population of roughly 24,000 people. It is a rural community that has been notably impacted by the opioid epidemic, poverty, and unemployment. These denote some of those common underlying system levels factors. In the 10 years preceding 2014, Scott County typically diagnosed 1 to 2 new people a year with HIV. Between November of 2014 and October of 2015, so roughly less than a year, 181 people in Scott County were newly diagnosed with HIV. 92% of those people were also diagnosed with hepatitis C. Additionally, on average, people newly diagnosed with HIV related to this outbreak were named syringe sharing partners 4 times more often than contacts who tested HIV negative. This indicates the importance of that shared behavior played in this outbreak. This was a huge alarm bell for public health officials. They began to question if other places in the U.S. could be the next Scott County. So they conducted a study to determine if there were other counties in the U.S. vulnerable to rapid HIV and hepatitis C transmission. In the federal study, they identified 220 counties that were most vulnerable to this sort of event. 41 of those 220 counties are in Tennessee.
So because of this, Tennessee now routinely evaluates county-level vulnerability across the state. We used chronic hepatitis C in young persons as a proxy to indicate where injection drug use is occurring, and then sought to identify predictors of local vulnerability, which you will see outlined in detail on the next few slides. So we started with 75 variables that we felt could potentially predict an outcome of chronic hepatitis C. We then applied a series of reduction techniques as well as by programmatically informed discussions to determine the final set of variables that we wanted to include in our model. For example, if we had 2 variables that were very similar, such as education level and income, we would choose the one we felt was the most predictive. In the end, 13 county-level data elements were identified as predictive of vulnerability to an HIV hepatitis C outbreak among persons who inject drugs in Tennessee. Of the 13 predictors, 4 were socioeconomic factors. These included percentage of youth or percentage of the population aged 20 to 44 years, vehicle access or percentage of homes with at least 1 vehicle, per capita income or the average income per person, unemployment or percentage of the population unemployed. 2 predictors were related to opioid use, multiple provider episodes, or MPE, a proxy for doctor shopping, and morphine milligram equivalent, or MME, for all opioids for pain. 3 variables were related to access to health care: primary care provider rate, or the number of primary care providers per 100,000 persons, mental health provider rate, or the number of mental health providers per 100,000 persons, and the percentage of clients in Tennessee Department of Mental Health and Substance Abuse Services funded opioid treatment and recovery. The remaining 4 variables were health outcomes: teen birth rate, or the rate per 100,000 births among females aged 15 to 19 years, premature death, or the count of premature deaths that occurred, HIV prevalence rate, or the number of persons living with diagnosed HIV per 100,000 persons, and the rate of syphilis infections, or the number of syphilis, including primary, secondary, early, and late latent cases per 100,000 persons. 11 highly vulnerable counties were identified across the state, with 5 located in East Tennessee, 4 in Middle Tennessee, 1 in Southeast Tennessee, and 1 in West Tennessee. The majority of Eastern Tennessee ranked as highly or moderately vulnerable, with 6 and 24 counties, respectively. Only 3 counties in the East were ranked vulnerable. For Middle Tennessee, 4 counties were ranked highly vulnerable, 24 were moderately vulnerable, and 13 were vulnerable. The West Tennessee region had 1 highly vulnerable county, 5 moderately vulnerable counties, and 15 vulnerable counties. This distribution demonstrated that Eastern Tennessee is particularly at high risk, but that vulnerability extends across the state.
So how do we take this knowledge and turn it into action? First, we need to identify and understand the connections between these health conditions. How do these diseases interact in the body? What are the shared behaviors that contribute to transmission? And what are the common social determinants of health underpinning them? It is only from first understanding these connections that we can identify solutions and strategies. These solutions will need to be multi-layered. We will need strategies that are individually focused, others at the community level to address things like stigma, and finally, structural or systems level changes that address the root causes of these health conditions and the broad spread of inequities our communities face. Finally, the strategies must consider how we can best integrate prevention and treatment services across these health conditions to prevent comorbidity and make services more accessible to all. So how will we do this? First, we plan to present local data about what is going on for the area across these health conditions to identify and understand those connections between HIV, sexually transmitted infections, substance use disorder, and viral hepatitis. This will also include the policy landscape and other social determinant of health data that will be useful in adding context. Next, we will present a variety of evidence-based strategies used in Tennessee and in other places across the country to address what the data are telling us. This is not meant to be prescriptive, but rather to get everyone thinking of possible solutions. Then we will break out the large group into smaller groups where folks will work together with people across various sectors to identify individual level, community level, and structural level recommendations and strategies. These conversations will be facilitated by a mix of local representatives and representatives from the Tennessee Department of Health and the Tennessee Department of Mental Health and Substance Abuse Services. Finally, we will bring everyone back together to share the strategies identified in the smaller group discussions and work towards consensus. Ultimately, these are the strategies that will be included in the final End This Endemic Tennessee plan. We recognize that what is happening in West Tennessee is different than East Tennessee, and therefore the strategies and priorities are likely to be different, which is why we are proposing regional engagement for these meetings. Over the next year, we'll be hosting virtual community planning meetings in the regions indicated on this map. There will be a total of 5 meetings per region. The first meeting will be centered around setting the goals for End This Endemic and discussing the overall framework and planning process. Then we will move pillar by pillar according to the federal Ending the HIV Epidemic framework: assess or diagnose, prevent, treat, and respond. These meetings will be facilitated by local tri-chairs, which includes people that are health department employees, community-based organization employees, and community advocates who are doing this work in their communities every single day. The meetings will also be facilitated by staff from central office, which includes people working at the Tennessee Department of Health and the Tennessee Department of Mental Health and Substance Abuse Services, as well as myself, the End This Endemic Tennessee coordinator. What do we anticipate the plan will look like at the very end of this process? First, we will make the case for creating an integrated plan by providing Tennessee-specific evidence of this endemic and making the ethical case for a framework that addresses both individual interventions and broad structural changes. Then we will detail community engagement. Who was engaged and how were they engaged? This will serve as a guide map for other jurisdictions that want to create their own End This Endemic plan. It will also signal to the readers of our plan how collaborative of an effort this truly was. Next, we envision a statewide chapter that will contain broad goals applicable to the whole state, as well as those higher structural level recommendations that would impact all of Tennessee. For example, one recommendation that may come out of this process is the need to modernize our HIV and viral hepatitis criminalization laws. Well, that recommendation, if implemented, would impact the entire state of Tennessee. Then there will be regional chapters. These will contain regional epi profiles, data about what is going on in that region for these health conditions, an inventory of existing resources. What are the organizations and strategies that are currently being explored in that region? And then the strategies and recommendations that came out of those regional planning meetings. So how can you get involved? Contribute your voice to identifying these strategies. Well, the best way you can get involved is by registering to join one of those regional planning groups so you can be a voice in those meetings. You can access a survey to join a regional planning group at the link indicated on the slide. The more voices we have at this table, the more successful this plan will be. So don't forget to invite your colleagues and your friends too. Together, we can end this endemic in Tennessee.